Good evening, everyone. I'm so looking forward to spending this little bit of time with you this evening. We'll take a little bit of time here to allow for people to jump on, considering we were trying to start right on time. So we just want to make sure that people have ample opportunity to join and listen to this discussion, as it is so important to so many of our uh, little and big patients that we take care of as pediatric providers. I'm going to be talking. My name is Lara Smith. I am a nurse practitioner who works clinically at St. Louis Children's Hospital. I apologize, I got a pop up about the speed. I am a nurse practitioner at St. Louis Children's Hospital in the pediatric ICU. And in addition to that, I am faculty at Rush University in the acute care pediatric nurse practitioner program. I have been working as a nurse practitioner for many, many, many years at this point, and so have had the opportunity to see many iterations of the respiratory seasons as we see them. Um, so I would like to share some of my knowledge with you. So I'd like to start this time with talking about one of our least favorite friends that we do see from the respiratory season, and that's RSV. So, RSV, as we well know, is something that we see every year. We see it in the pediatrician's office, in the nurse practitioner's office. We see it in urgent cares. We see it in emergency departments. We see it in ICUs. We see it everywhere. So it's something that goes across all of our specialties when we have patients with RSV. So starts with the typical symptoms that we all know. They start sneezing, they have a lot of congestion, they have cough and fever, and oftentimes a loss of appetite. And that could be for the older children, and then just really difficulty eating for infants. As we all know, they are obligate nose breathers. And two, babies really, the work that they do in their life is eating and sleeping and throw some crying in there. Um, and doing a little bit of activity, and so anytime anything takes up more of that energy source for them, typically the eating part is what falls away and they have more challenges doing. So these children sometimes will actually come in with some level of dehydration, more so than their respiratory symptoms. So oftentimes that will need to be cared for also, but they will come in with the typical respiratory symptoms. Really, the biggest thing that we have to offer for any families, from the primary care side and through a lot of the other things that we do even before they reach the ICU, is making sure that they get good clearance. It's good nasal clearance, nasal suctioning with ocean spray drops, and with suctioning, whatever methods that they use at home, in the offices, and on the floors, and even in the ICU, to really clear those secretions to allow for those children to be able to breathe through their nose so they can still, to go through their functions of the daily life. Um, they might need a little bit of oxygen, and then we kind of go down the line of the additional things that they might need. So certainly high humidity or high flow nasal cannula has really played a large role in caring for these children over the course of the past few years. It's really helpful. The humidity that is offered with that is really, really helpful. It kind of takes the place of needing the nasal saline drops for these patients to try and help clear those secretions for them. Um, rom cannula if there are a small baby to BiPAP. We certainly do use for these patients also. Intubation and even ECMO. I mean, we certainly have the gamut of things that we can provide to these patients, and sometimes that some of them need to be able to appropriately care for them. That said, we do have some newer modalities to help prevent these children from getting sick in the first place. So last season, we had our first season with nirsevimab. I have nirsevimab, sorry, um, that was available for patients. It unfortunately did not have the distribution levels that were desired throughout the population, which is actually an unfortunate problem, but also a good problem to have because families actually wanted it for their children. They wanted their children to get this to help prevent RSV. And so that was very important. I actually spoke with one of the reps from the company at NAPNAP's conference this year, and she said they were on board to be able to produce whatever and whenever we needed to help these patients this season. So the availability, I haven't heard any issues with availability, and so the availability of it should be there. So that's for patients up to 8 months of age during the season that they can receive. It's a one-time dose. You can receive it in the physician's office, and it covers the respiratory season. Its effectiveness, the early estimates for last season, the effectiveness was about 90% of preventing hospitalization and severe disease, which is huge. The uptake there were a couple studies on the uptake. There was one in a military area that had like 87% uptake. So I think that we don't have a lot of good data about what the overall population uptake was of it, but I think, given the request for it last year, I think the uptake was actually probably a lot better than for many of the other vaccines that we have seen recently. As of now, it is, as I said, recommended for 8 months. It is not given to patients whose mothers have had the RSV vaccine at least 2 weeks prior to their birth, because they should be covered with their maternal antibodies, and so they actually are not indicated to receive that during that time period. As of October of 2024, the combined vaccine, maternal vaccine and nirsevimab combination uptake was about 30%. They about not quite 2% was the maternal vaccine, or just under 1% was maternal vaccine, and actually almost 30% was the monoclonal. But then an additional 33.6% were actually intending to get the monoclonal, get nirsevimab for their child. So it was great to know. And then as of November 23rd of this year, there were of the pregnant population of women who were at least 32 weeks pregnant, approximately almost a third of them had received maternal RSV vaccine. So that was great news to hear. There's that many more children that we will hopefully be protected during the season. And so those are important things that we love to see. So hopefully we won't be talking about RSV as much anymore as time goes on, that these children will be able to stay out of the hospital. Our other typical nemesis, flu. We haven't seen a whole lot of flu this year, thankfully. The levels are low, but they're trending up. The typical symptoms, as we all know, mild URI symptoms, fever, big one, myalgias, big one. So those are really the big things that you run into with flu. So flu in and of itself, it's awful, but is survivable for most people. The things you are concerned about are people with comorbidities that can run into issues with that, particularly asthmatics. It's often very, very rough for, particularly H1N1. For any of us oldsters that were around when H1N1 its first go around in 2009, it was very, very hard on asthmatics. That population became very, very ill with it. The other thing that we worry about too is the development of necrotizing pneumonia on top of the influenza, which also, for any of us who have worked in here, is really, really awful, and one of the things we want to avoid with influenza. So as we know, there's actually quite a few antivirals that are available for the treatment of flu. I think most of us are probably familiar with oseltamivir or Tamiflu. That's the one you can get as early as 2 weeks of age and older. So that's the one that's available for most people. There are a number of other ones. Zanamivir is available for 7 and older. It's an inhaled powder, so that might be a little bit more challenging for people to take. Paramavir is IV. It's available for 6 months and older. Really, is only something I've actually even never seen it in the hospital. Oseltamivir is usually the go-to for most of these patients. Baloxavir is one that's available as a single pill, but not recommended for hospitalized patients. So there's many of them. I think again, most of us are most familiar with oseltamivir, and that's what we usually see. Best to start within 48 hours, and really on the outpatient side, it really will be started within 48 hours. Any patients that would receive it outside of that are patients with really significant comorbidities and risk of disease. And oftentimes, when patients are hospitalized and requiring therapies to support them with that, they can be started on oseltamivir outside of that 48-hour time period. But more often than not, it's just started within that first time period. Vaccine uptake this year was about 36.6% at the end of November. Though when polled, there were about a third of patients that said that they probably or definitely would not be getting the vaccine, which is unfortunate. And then Keisha, I see your question. Is that related to nirsevimab? I just, please, if you can follow up with that, so I can attempt to answer the question. I don't know if I'm going to have a good answer for you. The vaccine this year, the flu vaccine this year is the flu A's are H1N1 and H3N2. In Australia, the H3N2 was the predominant strain in this past season, so that's probably the one we're going to be looking at as far as the predominant strain here this season, and of course the one Victorian lineage B flu vaccine. And as we always all should remember, and I think the primary care people are probably a lot better at remembering this than we are, though anyone any child receiving their first flu vaccination, so anytime between 6 months and 9 years of age, they receive two a month apart. And so anytime anyone gets their first one of them, they do receive two. And then I'm sure everyone has heard about, or most people have heard about, the other bird flu that's going around. There have been some human cases of it here and there, though they haven't really determined transmission yet as far as where it came from. The only thing they've said is it does not appear that it's human to human. It's H5N1. It's an influenza A virus. There have been a total of 58 human cases. I think there was a child in California within the past couple weeks that they had identified. And as of the 6th, the USDA is ordering milk testing for the virus. And this is across all. This isn't just raw milk. This is just milk testing. And so they're going to be testing for that and really kind of keeping a close eye on that during that time period. Yeah, so someone had asked a question about the insurance coverage for nirsevimab. Unfortunately, I am in the ICU, and so this is not something that I am as familiar with. But someone else has commented, I've heard there's been good coverage for it, though it didn't have firsthand information. So if there's anyone on the primary care side that has more information related to that, I know last year with the people that were really, really trying hard to find it for their patients, none of them had anything specifically related to having challenges getting it paid for. But again, I think we all are aware that insurance companies can be a little challenging. COVID is still here, as we all know. The breadth of symptoms are broad. I think one of the ones that popped up, and I think probably about the third mutation of COVID was croup. And so we are still seeing that with some of our patients. And so that's probably a lot of what that actually is a big portion of the patients that we end up seeing in the ICU side are patients that either have significant comorbidities and they're just more ill with it, being, somebody's an asthmatic, or patients who have croup symptoms with it. Those are patients that we see in there. Um, Paxlovid is available, but it's not available for anyone under the age of 12. It needs to be started quickly. The hospitalizations, there's most hospitals have guidelines related to what and when you give dexamethasone and remdesivir. Usually it's if they're on any sort of oxygen support that is different or above baseline for patients who have some chronic illnesses that might have oxygen at baseline. And those are usually the situations where they'll give that. Our usual suspects of rhinovirus, enterovirus, we certainly have seen all the time. The last two I just kind of want to touch on a little bit. I'm kind of running over time a little bit, but I want to touch on a little bit that we have seen more of lately is mycoplasma pneumonia, so walking pneumonia. That's something that we've seen quite a bit more lately and have seen relatively healthy patients hospitalized, even in the ICU with it, because of their level of hypoxemia that they have with it. That's the one thing that's pretty profound with mycoplasma pneumonias. They actually are pretty hypoxemic when they come in, and so they actually do require some support related to that. The incidence in this past year had doubled for 5 to 15-year-olds, so up to about 7.5%. And we've actually seen quite a bit of it in 2 to 4-year-olds, which is not, as we all learned in school, wasn't necessarily an age group of patients that we really thought about mycoplasma with as much. But, about almost a little over 7% prevalence in that population, which is an increase from less than 1. And so we are seeing a significant amount of mycoplasma with these patients. It's a really long incubation period. It's not something we test for typically. They have a cough for a really, really, really long time, and it's a pretty rough cough that they have. They usually recover well, but it is something that we're seeing more and more of. So what do we do with that? You want to start macrolides for these patients, and that's what you treat them with. However, we are seeing some resistance here. And so, according to the CDC's website, we really don't have much in the way of resistance, but they actually have had a reasonable amount, actually in the Northeast, specifically that I know of. So when they are resistant to macrolides, you would jump to using doxycycline or levofloxacin for those patients. And so just something to think about if you have a patient who has mycoplasma pneumonia and they're on macrolides and they're just really not getting better or getting worse, would be a time to think about if they do have a strain that's resistant to the macrolides. And then pertussis, unfortunately, is really starting to rear its ugly head a little bit more. I think we all know the catarrhal phase, the paroxysmal phase, and the convalescent phase. The paroxysmal phase is the one where you have the whoop with the cough. The catarrhal is when you just have URI symptoms that kind of leading into those things. So macrolides help with severity. Really need to start within 3 weeks of symptoms for it to help. Though infants, that'll stretch out to about 6 weeks. That you can start macrolides for them and to really help support them through that. Don't forget that with particularly neonates and very, very young infants, you have the risk of hypertrophy of the pylorus with erythromycin specifically. So don't forget about that and think about that when you are giving that to those patients. So the cases had dropped quite a bit during COVID because people weren't around each other, but they have returned to pre-pandemic levels. And as of November 30th of this year, there are 6 times as many cases reported for 2024 as there were in 2023. And those cases are higher than they were in 2019. And so we're seeing a lot more of this. And it's, really unfortunate. And I think there's a large area of vaccine coverage that's related to this. So looking at the data on VaxView, which is the CDC website, and they're categorized into age groups. It's a great site. They have great dashboards. Great graphs. Highly recommend looking at that if you're having any curiosities about immunizations and vaccine uptake. But the adult uptake is around 40% overall. So this was recommended for adults in 2005. But the uptake's around 40%. It's a little bit higher up until, 40, 45. I think it's around maybe 46%, hovering right above 40 for that 45 to 65, and above 65 is actually below 40%. So, we want to encourage grandma and grandpa and great grandma and great grandpa if they're going to be around the babies, especially, if anybody's sick around the babies, they want to really try to encourage them when they have to get their next tetanus shot, because they can get their next tetanus shot. They're going to want that because they don't want that either. To really encourage them to get the one that has a pertussis vaccine in it, just to try and protect these kids, because it's a rough one. These babies are coughing, coughing, coughing. They're having trouble keeping their food down. And again, not unlike RSV, the babies can get really sick with it, and certainly anywhere from needing a little bit of oxygen to needing ECMO. So they can get very, very ill with it. And so we want to avoid that for these kiddos. I can see Danielle was putting all kinds of articles in there for me. But I just want to open it up and see if there's anybody that has any questions about anything. Yeah, I apologize for not having more information related to the insurance coverage. And honestly, like I said, and I think we all know, I think the variability of that, I think makes it a little bit difficult to discuss, because it is so different, so many different places. Well, I don't see anything else popping up in the chat, in the comment section, and so I, as I think we all like to be, I want to be very thoughtful with other people's time. But I do appreciate you all that were able to show up. I'm looking forward to for everyone to be able to, who didn't have the time this evening, because I know we're all super busy with our lives, and it's December, and so life is crazy. So, but I appreciate all of you that were able to attend tonight. I'm looking forward to hearing, feel free to contact me with any questions or anything related to this, if you have the opportunity to watch it at a later time. Thank you so much for your time tonight, everyone.